to us in Brooklyn as much as possible. Because when you pick up the paper, there's plenty of information on the national scale about this crisis. But it looks very different depending on which community you're sitting in. And that's what I want to try to bring us to today. So what is this crisis that we're speaking about? And from the perspective of New York City, we are in a moment where someone is dying in our city, in one of the boroughs, every 7 hours from a drug overdose. So think about that. In the course of the day, every 7 hours, we're losing a life to this epidemic. And that's not exclusively an opioid issue, but this is really being driven by opioids. Just to put that into further perspective, right now more New Yorkers die from drug overdose than homicide, suicide, and motor vehicle accidents combined. So this is a leading cause of death in our community right now, and that's why we're here to talk about it, because there are things we can do, and we can do together as a community to try to turn the tide on this issue. So what does that mean? In 2016, there were over 1,300 drug overdose deaths in New York City. So that's bringing us down to a number. And what's driving that? So I said it's not exclusively opioid related, but opioids are involved in about 8 out of 10 of those deaths. So about 80% of those overdoses do involve some kind of opioid. And when I'm talking about opioids, I'm talking about heroin, but I'm also talking about pain medications that folks are getting a hand on in terms of pills, things like OxyContin, Percocet. I don't want, I'm leaving some out, but those are some of the big players. And the other thing that's playing an increasingly large role in this crisis in our area is a medication or a drug called fentanyl. Fentanyl is an extremely potent opioid that is being mixed into the drug supply in various ways. And so someone that may be used to using heroin and doing that on a regular basis suddenly gets a hold of a batch that is extremely stronger and more potent than what their body is used to. And that is one of the things that's really driving overdose increases in the community. Another interesting thing is that the fentanyl is being mixed not just with heroin, but it's being mixed with other drugs, including cocaine. So folks who may not be used to or even know that they're using opioids are being exposed as they're experimenting perhaps with other drugs that are considered less dangerous and less likely to cause overdose, but inadvertently putting themselves at risk for an opioid overdose. So this dramatic increase over the last several years, and I want to say that we're in the midst of the 7th consecutive year of dramatic increases in the number of overdose deaths in New York City. It's reflective of a national trend. We're seeing this all across the country. But it has very local consequences. So let's talk about Brooklyn in particular. And I'm sorry you can't see my graphs, but I didn't know we were going to be able to project slides. I have copies, probably, if anyone wants to grab from me afterwards, or I'll put them on the table. And this data is all also available through the New York City Department of Health. So through their website, you can access a lot of this. That more than 1,300 deaths in 2016, 297 of those occurred in Brooklyn. And that's actually the second highest number if you break it down by borough. The Bronx is beating us. They had 308, but we are coming in number 2 in terms of the number of overdose deaths. Now, if you break that down on a rate based on population, Brooklyn is quite a bit lower because it's got a larger population. But that's a substantial number of lives lost in our communities, among our neighbors, that I hope we can take a stab at making some change on. And who's dying? So the highest, and this is, again, specific to Brooklyn, and this looks very different, I think, than other parts of the country, even other parts of the city. The highest rates of death are actually in folks that are in their 50s and 60s. These are not young kids always. We know that a lot of these deaths are occurring among younger individuals, but there's a substantial portion of older individuals who are getting into trouble with opioids. Up until data inclusive of 2016, the highest rate of deaths from unintentional drug overdoses. And this is going back to citywide data. I don't have this data by borough. However, if we want to look at sort of who's being impacted, whites continue to have the highest rates of overdose deaths. But African American Black communities are having the highest rate of increase in overdose deaths. Over the last year, the number has pretty much doubled among Black communities. So we do see disparity, we see differences based on community, but we also see things moving in a direction that we'd rather not. All these rates are going up. So that's to give us a backdrop. What I want to touch on is really sort of 3 categories of strategy that I think we as healthcare professionals and we as communities working together should consider employing to try to turn the tide on this epidemic. And one does come primarily down to providers of healthcare. We need to be smarter and more careful about how we prescribe opioids. Pain medication, overabundance, easy access has driven a large portion of this epidemic. So we have new tools at our disposal, things like a prescription monitoring program where I as a prescriber can go in if I'm meeting a patient and considering giving them a prescription for a controlled substance. I can now go into a computer database and see whether they've received a similar prescription from any other provider and filled it in New York State. So this is new something that we didn't have 5 years ago that we now have access to, and that's been very helpful. This is also a place where community members and family members play an important role. I go every once or twice a year, I go in my mom's medicine cabinet and see what's in there, right? And help her get rid of what is 5 years old or 3 years old that's been sitting there. And this is a role that we can all play. When you look at the misuse of prescription opioids, that is the pain medication pills, most people get those from a friend or family member, especially in the early course of their use. So they're just finding it, or maybe someone's giving it to them, but more often it's just discovered and the person that left that laying there may not even know that it was used by a family member. So as family members, we should have some surveillance over what's in our medicine cabinets. The second issue is once folks are identified as having a substance use disorder, helping connect them to care. And our next speaker is going to talk quite a bit more about that. But I will just say there's lots of options in terms of treatment for opioid use disorder. And hopefully during the Q&A, we'll be able to discuss that in more detail. The third item on my list here has to do with overdose reversal. And how many folks have heard about naloxone? And how many people know where to get it if you want it? All right. So naloxone, for those who are not familiar, is a medication that can reverse an opioid overdose. And our goal as providers is to get it into the hands of as many people as possible, because you never know where you might come across someone who's in trouble. And so for those who want more information and would like to receive specific instruction and even get naloxone, you'll have that opportunity as we're concluding today. So that, I think, is an important tool to empower communities to respond to this crisis. And I've had several folks that I've worked with that may be in treatment themselves or in recovery themselves who've had the opportunity to save the life of a friend. And it's a very powerful tool. And it's very powerful for their own recovery to have that power and opportunity and experience of saving a life. So through these three pathways, safer prescribing, linking folks to care, and also overdose reversal, I think we have a lot of tools at hand if we work together as a community to start making some impact on this epidemic. And I look forward to discussing that further as we move through the speakers today. So thanks again for the invitation, and I'm going to stop there and look forward to some time to answer questions. Thank you.
Before we introduce our next speaker, we're going to ask State Senator Jesse Hamilton to share a short greeting.
Good evening, everyone, and welcome to the Children's Brooklyn Museum for a very important topic that is plaguing our state and our nation, fighting back against the opioid epidemic. We're here tonight to listen to important perspectives on the opioid epidemic, to gain insights from perspectives that overlap and intersect public health perspective, policing and law enforcement perspective, and on-the-ground community perspectives. We are dealing with the problem of drug dependence and substance abuse. And over the last decade, we're seeing a rise in deaths due to opioid epidemic. From 2010 to 2015, the opioid overdose death rate has doubled. From 2010 to 2015, the heroin death rate has increased by over 5 times. And I always say we have to raise the awareness of sharing knowledge and to build up organizations across the state to combat the stigma of drug abuse and to make sure that our families understand what they need to help to fight this opioid epidemic that's plaguing our city. Upstate New York, in general, we talk all the time about the opioid epidemic and how it's destroying families. It's classless now. It's affecting all, if you're with money, without money, doesn't matter of your economic status, it's affecting everybody. And I still understand why it's happening now across the state. And I guess that's what we're going to find out tonight, Yakov, how to deal with that. But I just want to say thank you, Yakov, for putting this together. It's an important topic that's affecting our community, and keep up the good work. And thank everybody for coming tonight. Thank you so much.
Good evening, everyone. I'm Margaret Walton from Brooklyn Children's Museum. I thank you all for being here. I thank Yakov Berman for choosing us as the venue for this very important discussion. The museum is always interested in joining in efforts that help our community here in Crown Heights and in all of Brooklyn. I'm also here to introduce one of our speakers, Dr. Brian Sands. He is the Section Chief, Substance Use Disorders Services for the Department of Mental Health, the Veterans Affairs Harbor Healthcare System, and a clinical assistant professor at the NYU School of Medicine. Previously, he was director of the Chemical Dependency Division of the Department of Psychiatry at the North Brooklyn Health Network, and had been on the faculty of Tufts and Harvard Medical Schools. He also serves on the medical advisory panel to the Commissioner of the New York State Office of Alcoholism and Substance Abuse Services. Dr. Sands is leading an initiative in New York State and New Jersey to ensure that all veterans with opioid use disorder get effective treatment with a medication-assisted therapy such as, and I hope I'm pronouncing this right, buprenorphine, methadone, or injectable long-acting naltrexone. Dr. Sands also introduced buprenorphine prescribing to New York City Health and Hospitals at Woodhull Hospital and provided training, mentoring, and consultation to other psychiatrists in the mental health clinic to get waivers and to prescribe. So please welcome Dr. Brian Sands. Thank you.
Well, thank you for that wonderful introduction and for the invitation, and thank you, Yakov, for the invitation to speak here. It is a beautiful museum, and I could hardly help myself from wanting to go look at some of the exhibits when I as I was coming up the stairs, but they said, it's closed for now. But I have to come back. So my job is to make something that on one level is hard to understand easier to understand. And that is what addiction, and in particular addiction to opiates, really is, and how it happens that people go from leading normal, healthy lives to dying of their addiction. So pretty much everything I say is going to apply to all drugs that people abuse, but we are specifically talking tonight about opiates. And as you've heard, the number of, the amount of opiate pain medication that's been prescribed by doctors went up enormously, like it quadrupled in the last decade. The one piece of good news is that it actually peaked in 2010 because of some of the things that you heard about from Dr. Whitley. So we may start to see some benefit of the fact that we are now we are still prescribing too much, but at least that number is going down. So what did that do? Why did prescribing so much create a problem? It created it in two ways. One, that when you prescribe medicine like that, some of it is going to get diverted. Diverted means stolen, people going to doctors and who don't really have pain and getting prescriptions and selling them. There was a lot of this medication that became available for people to buy in the street. And also, a lot of it was available in grandma's medicine cabinet. And it's particularly tragic because, we, as a society, we learn our lesson and then forget it, and learn our lesson and forget it. We were, I think, remembering the lesson that heroin was a bad thing. But here comes, and a lot of the kids that I know probably would not have thought to try heroin. But this pill, grandma's medicine cabinet, it's made by a pharmaceutical company with production standards, and so it's a much lower bar in terms of risk. And a lot of kids and adults have taken these pain medicines that they get from illicit sources and have become addicted to them. And then, because of some of these measures that we're taking to decrease the inappropriate prescribing, we are prescribing less and it's gotten more expensive, and so they then turn to heroin. So we have a pathway of people basically starting on an opiate abuse addiction because they thought it was safe to just take a pill here or there. And if it had just been heroin, I don't think, people would still do that, but it would be fewer. And a startling statistic is that, back in the 60s, if you looked at people who were seeking treatment for drug abuse, 80% of them, for heroin abuse, 80% of them started using heroin. That's what they started, that's what they were using. By a few years ago, 80% of the people who were admitted for treatment of heroin dependence started with prescription pain medicine. So that's a pretty stunning turnaround. So, and it gives you a sense of how the prescription opiates are a kind of a doorway into, and they can be very dangerous by themselves, and people die from overdoses from prescription opiates, but they also lead to heroin, which has so many more problems, including it's being mixed with fentanyl. Those are two ways that having too much of this, too many of these drugs, has hurt our society. A third way is, so when I went to medical school, it was common knowledge that you only prescribed an opiate if someone was dying and had terrible pain, like they had cancer, or they had had an injury or surgery, and they needed some pain management, for a few days, for a week. And we never, ever would have prescribed it for, someone with low back pain, with the idea basically that it would be forever. And there was a whole lobbying effort on the part of one company in particular, but the pharmaceutical industry, to make it more commonplace for people to want opiates and for doctors to prescribe them. And it worked way too well. So in essence, there are a lot of people in America who are taking prescribed opiates, taking them exactly like their doctors have told them to, but are at risk for overdose from those, and also at risk for moving in from medical use, which is using it how your doctor says, to non-medical use. And when this was when the lobbying was going on, there was one study that was cited that said that fewer than 1% of people who were treated chronically for pain. Does that mean that the slides work? Or? Oh, okay. Or maybe not. Oh, okay. We sort of got into, so this is what I was talking about here with increased prescribing, medical use. So it had been said that less than 1% of people who were treated chronically for pain went over into more of an abuse of the medication. But it's now clear that it's more like 25%. So of these millions of Americans who were prescribed pain medicine for things like lower back pain, 25% of them have moved from taking these drugs as prescribed to taking them in a more getting high kind of way. And so you ask yourself, and like, why does this happen? Why does this drug do this to people? And so let me just take a step back and say, as a culture, as a society, we've known about opiates from opium for a very long time. And it has wonderful properties in relieving pain. And it also, in 7/8 of people, makes them feel this kind of warm, fuzzy, good feeling. It raises people's moods. Not with everyone, though. It's interesting. There are some people who are kind of genetically protected from addiction because they really don't like the sensation of taking an opiate. So when you take an opiate, I mean, presumably it's prescribed to relieve pain, but you also might feel euphoria, some sedation, respiratory depression. Your pupils get small, something to look for if you wonder whether someone around you is using. And of course, if you have pain, it'll be decreased. But the problem is that it lasts for a certain amount of time, and then as the drug leaves your system, you have withdrawal. And even if you've just taken it for a few days, 4 or 5 days, you're going to have withdrawal in between doses. And it's not, if it's just 3 or 4 days of taking the medicine and then stopping, the withdrawal isn't going to be as severe as some of the things on the right hand there. But these are the things that happen when you've been on it for a while, like a few months, and then stop it abruptly. So you feel awful, dysphoria, like resembling depression, restlessness, insomnia. People cannot sleep for anything. They're wandering around. They feel like everything in their body hurts. They're in pain everywhere. They're irritable, they have mood swings, nausea, vomiting, runny nose, that's very characteristic, goose flesh, and a lot of yawning, and their pupils would be very wide. So, so this drug, when you take it, makes you feel good, and then it makes you feel very bad. And so that cycle of taking something that makes you feel good and then makes you feel bad is something that can train people to need this drug. And I'm going to, there are factors, so the way I made this slide, there are factors that affect the individual person, and those are the central ones. The reinforcing effect of the high, that is, some people genetically do not have the same response to these drugs, and how low people feel when they have the low. And then there are things like, what else is there in your life? If a lot of kids experiment with different drugs and don't get addicted. A lot do, but a lot don't. And the reasons why they don't is because there are other things in their lives that they care about and they don't want to give up. And so when you're thinking about your own kids and how to keep them away from this, making sure that they have a sense of who they are and what their purpose is and feel like they can communicate with you is essential. And then the things that are around that in the society are, is the drug available? What are the risks of obtaining the drug? And general societal attitudes. And in terms of like how addictive is it? So it's interesting, tobacco is the most addictive drug, or nicotine. After that is heroin. And what this says is that roughly a little less than 25% of people who take heroin will get addicted to it. So 75% don't. And the people who don't try it, and they may like it or not like it, but they have reasons to not want to take all of those risks, and they don't. So I mentioned a cycle of withdrawal, craving, and it just goes on and on. And to make things worse, it fundamentally changes the brain, and that's why we say this is a brain disease. The basic thing that you just need to understand about this chart that I put up is it's a measure of people's mood. And at the very beginning on the left, someone takes a drug and their mood goes up. Then it goes down. And then they take the drug again, it goes up again. But gradually over time, the brain adjusts. And so it's no longer even possible for them to feel normal. And so they start off taking the drug to feel high, to have this good feeling. But they end up taking it because if they don't take it, they feel absolutely horrible. And so, I mean, this is the ultimate slippery slope. At the up front, in the first few times of trying it or a few months, it's a lot easier to make a decision to say no. By the time you've gotten into it, a few months, you can't. It's really not. I mean, not that you can't, but it is a very, very difficult thing. So I'm going. There's also the idea that basically, if you feel bored or sad or unhappy, there are things that you can do, and you can do those things and learn that you can change your mood and it helps you feel good about yourself. Or if you take a drug, basically what you end up learning is that, hey, I can take this drug. That's it. That's what you learn. And your repertoire of things to do when you don't feel good, shrinks down. So this is a little sort of graphic of the brains of adolescents growing up. We brains develop until people are at least 20, maybe 25. And one of the things that develops is the ability to plan, and to have inhibitions, to stop something that once you've got started. And kids are very bad at that, which makes them very vulnerable to drug abuse. So just to summarize, there are genetic, we'll skip the epigenetic, early life experience and social things that make kids more susceptible. The availability of the drug is critical. I mean, if it's not there, you can't get addicted to it. And then if someone's exposed, whether they actually get addicted will depend on a lot of things, like how well they've adapted to other things in their life. So then just to briefly go through, what have we been talking about? On the left is opium poppy, and on the right, so this slide shows naturally occurring opioids, morphine, codeine, and thebaine. You probably haven't heard of thebaine. It's not a concern. I mean, the fact that you haven't heard of it isn't a concern. Morphine is available in many different forms. It's injectable. It's available in pills. And then the next grouping are semi-synthetic ones, things like heroin or Vicodin or OxyContin or Opana or Dilaudid. These things are much more powerful than the original ones, and so easier to overdose on. And then finally, we have fentanyl, which you heard mention of, which is 100 times more potent than morphine. And then even when, so if you just touch pure fentanyl, you can absorb enough through your skin to stop breathing and die. Law enforcement, people have to be very careful about that. So, I mean, when you think things have gotten really bad, you can take it one step further, because there's this other medicine used to tranquilize elephants called carfentanil, which is 100 times more potent than fentanyl, which means that it's 10,000 times more potent than morphine. And some of that is beginning to be seen on the streets. So I'm realizing I'm looking at my screen, but I haven't advanced your screens, which I apologize, but I guess it's now. Anyway, this picture shows you the amount of heroin that you would have to take to overdose and die, and the amount of fentanyl. So, not very much is the bottom line. And, as has been mentioned, where do people get this? 56% get prescription opioids from a friend or family member, 19% from a doctor, 9% bought them from a friend or family, only 4% from a drug dealer. And ultimately, this is a tragic common endpoint. And the trajectory of people, once they start using prescription opiates, and it doesn't take very long to get to a critical problem. What this slide shows is the results of some research done by the National Drug Research Institute. And basically, it's showing what they found was that in New York, on average, the first non-medical use was 16.7 years. So 16-year-old kids, that's the average age that they're trying these drugs to experiment. Then when they run out of money to buy those drugs and they turn to heroin, the first use of heroin is at 19 years. And then first heroin inject, so they start snorting it, breathing in their nose, but it's more efficient to do it with a needle. So they start injecting at age 20, and then they may get into drug treatment around the same time, and then have their first overdose a little bit after that. So first overdose at 20, first of many. And I think I'm out of time, but basically, let me mention something that I think in this community, which is if you sit down with your kids and have dinner with them and talk to them, that is remarkably protective. There's actual research that shows that for teenagers who have fewer than 3 family dinners where they actually sit down and talk to their parents, they're 3 times more likely to try marijuana, 2.5 times more likely to smoke cigarettes, and 1.5 times more likely to drink alcohol. And then finally, so the best thing that you can do is really invest time in your kids early on and talk to them and have the ability to have an open dialogue and let them know that you want to know what they're doing. But if you do get addicted to this, you really need to be on a medication treatment. It's very hard once you're addicted and once your brain has changed to stop with all of the psychosocial treatments. So we have 3 really good treatments. One of them is methadone, which has a reputation. Another is buprenorphine. It can be prescribed in any doctor's office, any doctor who qualifies after taking a 3-hour course, basically. So the potential for people to go, the problem with methadone is it's stigmatizing. You go to a methadone clinic and you're a methadonian, and you meet other people who are on methadone, and it's not a great experience. But you could get buprenorphine in theory from your regular doctor, or at least a psychiatrist. You don't need to go to a clinic. You can go to someone's office. And then most recently, there's a drug that is fantastic. It is an injectable form of naltrexone, the same drug that was mentioned to reverse overdoses. This can be injected once a month, and it blocks people from getting high. And so these other 2 treatments, the buprenorphine and the methadone, are keeping people from using and keeping them and having them feel normal, but they are taking a medicine. With the naltrexone, it's pretty much like they're not taking medicine, because the naltrexone just blocks opiates, and if you're not taking opiates, it really doesn't have any effect. So particularly for a young person, that would be my first choice. But the bottom line is, if you do encounter someone who is addicted to an opiate, one of these 3 medication treatments is going to be necessary for success in treatment. So let me stop there, and again, thank you.
Before we hear from our next speaker, I'm going to ask our Assembly Member Deanna Richardson, to share a short message. Assembly Member.
Good evening, everyone. I'm very pleased to be here this evening as the opioid crisis really, really is a major issue across the entire state of New York, as well as in our very own Crown Heights community. And let me just thank Jacob Berman and everybody who came together to make this event possible. The doctor was really sharing some great information. I was privy to that, and I'm grateful. And what really stuck out to me the most was the conversation piece. How we are speaking with our children, how we are speaking with our peers, and just opening up and having that real honest conversation about what's going on within people's lives. Whether it be depression, loneliness, or something, because people use substances to try to really escape from their reality. There's always an antecedent outside of joy sometimes that will lead you down to that pathway. But the truth is, just one hit, so to speak, really can be addictive and it's hard to turn back from. At the state of New York, I'm proud that we have been able to pass a really aggressive opioid legislative package where there's a lot of funding to combat opioid. And also there is a drug treatment center, whether you know it or not, right on Nostrand Avenue and Lincoln Road and Eastern Parkway on the corner there where the former bank was. And I think it's important for us as a community to know where the resources lie so that individuals in our community do not have to go far and beyond to get help, but help is here. And I just want to say that my office is always open. We're on Empire Boulevard between Nostrand and Rogers, 10 a.m. to 6 p.m. I'm really a non-judgment person, a child of Crown Heights. And so if there's something that is going on, truth is a lot of people in our community suffer in silence. They think that if they bring their issues to the forefront, people are going to look at them with a judgmental eye. I'm here to say that my office is open to you for that. So again, thank you. I don't want to take up too much time because I believe that the question and answer period is vital. Thank you.
Hi, good evening. My name is Sara Benjamin, and I was asked to come speak about the loss of our son, Kasriel. His friends knew him as Kazi. 6 years ago, on a beautiful September evening, we got the most devastating phone call of our lives. We were told that our son was very sick and that he had overdosed, and we should the paramedics were going to take us to his apartment. We were living in Flatbush. He was living here in Crown Heights. He was 25 years old. His roommate had found him. We weren't told. He had been actually dead for many hours. His roommate came home at the end of the day, and I'm not quite sure where we came. We just stood around for a little bit. Then we went home and arranged his funeral. One of the truly traumatic and devastating parts of this is we had no idea. It's probably not a typical story. We did not know he was a drug user. I don't even know now if I would have known what the signs. From doing a little bit of asking questions and stuff, since then, during the first few weeks, it seems that he had been doing prescription painkillers, but it didn't seem like it was that long. And as far as we know, this was the second time he'd used heroin. We took from his apartment, his siblings went back to his apartment, cleaned it up, and they found some bags of heroin and his cell phone. He had made a call to a dealer early in the morning, and apparently overdosed sometime later that morning and was found in the evening. First of all, we did have family dinners every night, and we were very close. The only things that I noticed in that, he had been very overweight since adolescence, so there was a food addiction going on, some kind of a eating disorder going on. We had tried to get him help for that. It wasn't successful. We really didn't, nutritionist, therapist, we didn't really know where to go with that. And he had been losing weight the last year or two. He had lost a lot of weight, probably more than 100 pounds. But the weird thing is he didn't look sick. He looked fantastic. He was getting so many compliments, and he started going out with girls a little bit. He was dating. He felt great. I mean, he looked great. I don't think most people knew anything. Maybe a few friends knew. Nobody said anything to us for sure, and we didn't know. And we saw him often. The only other thing was maybe 6 months before that, we were talking on the phone one evening, and he said, sometimes I have terrible anxiety. Sometimes I can't even get out of bed. And I was like I didn't know that about him. He was a very outgoing, jolly person, like millions of friends, very close friends, easygoing guy. And I had never heard this about him before. I had no idea. I was a very sensitive person, but anxiety did. And all I said to him was, you don't have to live with this. It's treatable. You can get treatment for this. And I figured he's 25 years old. Whatever, maybe he'll take me up on it. And that was it. Those were the only real signs that we had. Honestly, though, had I known, even now, and I know a lot more now than I did then, I still don't know what I would have done. I don't know with the anxiety, I don't know who I would have told him to go to. I don't know, would I have made phone calls, and even then, like someone that could take our, that would take our insurance, that was good, that could deal with particular things. Had I known that he was on, painkillers, I probably would have thought there was time. I wouldn't know that he would die that quickly. And even then, I wouldn't know where to begin. Who would I call? In our community, it's not a thing really to talk about, and we were open about it, well, partly because everybody kind of knew already. He had a lot of friends, and they knew, and it became kind of stupid to say, no, he had an aneurysm or whatever. So we were open about it. But also, I don't think it's a thing to be ashamed about. I think if anything contributed to his death was him keeping it to himself and being alone with it and not confiding in his friends and not confiding in us. And he knows we would have helped him. And and if I give into the shame, then it's saying, somehow I was responsible for this, and I can't even let my brain go there. It's too awful to even think about that. And besides, he was feeling, for whatever reason, he was feeling bad, and he found something that made him feel better, and it worked. It's not a moral issue. I mean, it was just somebody that was in pain, and he found something that killed the pain, and he kept doing it. And he probably was very careful of it. He tried it once or twice, as we heard. So I'm just surmising now. I don't really know, what happened. But I do know that I still, 6 years later, I'm clueless in terms of how, if I needed to get help quickly for somebody, how I would do it. I wish it would be as straightforward and is to call up, the pediatrician or the family doctor and say, my kid broke his wrist. Where do I take him? My kid has strep. What do I do? And I wish it would be that easy. I wish, the doctor's office had a little poster up, or I could just call and it would be be taken care of as a medical issue, and not just that, anxiety or whatever was going on with him. I wish there were ways to identify these kids who are not managing, they're isolated, and it's funny, he was surrounded by friends, but I guess he was alone, and I think that's the main thing that I would, if I could make a difference now, is that we shouldn't be alone. He shouldn't have had, whatever he was suffering with, I wish he could have reached out and there would be no shame involved in it. I wish it would be easier to find the help. And I wish, the people who are worried about their family members could talk openly about it and with each other and support each other and lose the shame, which is very prevalent, and especially in the Orthodox Jewish community. Even I'm thinking, if you had told me 20, 30 years ago, you're going to have a kid die of a heroin overdose, like, what? What? So anyway, so I'm really left with more questions than ever. I really, I have no answers. I don't know. If I, I've been asked to speak. The thing I can offer is trying to be open about it and say, listen, it can happen to a kid that seems fine. He seems okay. He was popular. He did okay in school. He wasn't a junkie. He was a regular guy. So that would really, I'm supposed to open up the thing to questions, the evening to questions, and I have lots and lots. I think my main question would be, if I would have to do it, if I would do it over again, like, who would I go to? Like, what would be my first phone call? Who would I call? I have another question also, and it applies in this particular case. There's a lot of talk about, we've heard about people hitting bottom, and there was no time for him to hit bottom. Like, I think that was, in those days, I thought, like, if a person gets bad enough, he'll hit bottom, and then he'll reach out and stuff. And he died way before he hit bottom, as far as I know. That was his bottom. So that seems to me that's a pretty dangerous model, and I don't know if that's a thing now. I have no idea. So I don't know if I have a particular question, except where would I reach out to get help? Is there anything that I could have looked for, that I could have, identified? And I would ask Dr. Whitley or Dr. Sands if, you have any guidance for me here, and anybody else that might be dealing with it.
So I am very sorry for your loss. And what you said is absolutely true. There are kids who seem to be doing really well, thriving, who have this addiction. And there is so much shame about it. People don't want to talk. And also, I just want to make it very clear that although I said some things about talking with your kids and being open, having dinners and all that, it's not to imply that if someone becomes addicted to an opiate, it's because their parents didn't do enough. You can always do more, and it's good to try to do more, but there are people who, as you said, he was in pain. His brain had a particular affinity for this drug, and when he found it, he really found something that he liked. And you should have been able to call your pediatrician and say, well, or if that's, or his family doctor if he went past his pediatrician, and say, this is the problem. And he could have been referred to a doctor who specializes in this, who could have prescribed buprenorphine, which would have given him a lot of the same feeling that he gets with the other stuff he was taking, but much more safely and much more evenly, so he doesn't have these ups and downs. And doctors your own doctor might even be able to prescribe it themselves. That's a decision that doctors make, and something that we need to do in the medical community need to do a lot more of, to make physicians open up and not just have specialists taking care of this. But there are specialists. We are in New York City. We have a lot of options. So there is also a hotline, and OASIS, the Office of Alcoholism and Substance Abuse Services, has a website where you can find resources. People have tried to make these things accessible, but I think what we're hearing is that at least 6 years ago they weren't so accessible. Yes, do you want to?
Well, So thank you. That's one I wanted to give a plug for. Yeah, so it is sometimes a complex maze to walk through, and I share your vision that it should be as easy as calling our family doctor. But much of the care at this point in time still lives with specialists. New York City Department of Health has a hotline. It's NYC Well. You can access it by phone, by web, or by text. Give some limited information about the type of help that you're looking for and get recommendations. So that's a great resource to be aware of. And 188 NYC Well. I was trying to Google the number, but now you got it for me. So that's an important resource for everyone to have at their fingertips, be it addiction, depression, anxiety, and that's come a long way in the last 5 years. So it's much more well developed than it was when you were struggling with this. So. And local, hospitals, and there are treatment facilities in the community. Certainly Kings County, which is I'm most familiar with, has an abundance of resources for treatment. But sometimes it is hard to get the right phone number and the right person on the line, in that moment of need. So we strive, I'm sure, to make that easier. Thank you very much. Yeah, thank you.
Thank you.
Good evening. My name is District Leader Jeffrey Davis. Mother, where did she go? Sara. Condolences. Deep condolences. We stand with you. I want to introduce someone. Can you hear me? A representative from Commissioner Arlene Gonzalez Sanchez is Patricia Zuber-Wilson, Director of Government Affairs and Federal Policy for the New York State Office of Alcoholism and Substance Abuse Services. In this position, Ms. Zuber-Wilson serves as liaison to federal, state, and local government agencies and elected officials. To this position, she brings over 30 years of experience in public sector. Prior to Ms. Zuber-Wilson's appointment in 2007, she worked in both the executive and legislative branches in public and higher education. She come? And I want to thank Yakov for putting this together. Thank you.
Good evening, everyone. Before I begin my comments, I want to add another part to my bio. My name is Patricia Zuber-Wilson. I am an ally and an advocate for people in recovery. Because of recovery, I developed a relationship with my late aunt, who was an alcoholic, and I discovered a relationship with a cousin who was also a heroin addict. I say what I'm about to say not to brag, but to tell many of you I know where you are. And again, with everyone else, please accept our condolences. I'm a fifth-generation college graduate. My family as a family members were for generations lawyers, doctors, professors, educators. Addiction, the stigma of addiction, bred deeply in my family. My cousin Eugene, I always used to hear stories about my cousin Eugene and how my grandmother had to go to the morgue in the late 40s, early 50s to identify my cousin Eugene's body because he came from Virginia to go to college in New York City. It was only till recently that my mother said to me, "You know your cousin Eugene died of a heroin overdose." It was the big secret of our family. And I used to hear little stories about my cousin Fonnie, who too came here to go to Columbia University from Virginia, and how my cousin Fonnie took his son's bicycle from under the Christmas tree, never understanding why everybody was so secretive about that situation. It was because he was addicted to heroin. But he got into recovery. So, you asked a question earlier about things that are going on, and let me give you a quick, real brief overview. Who OASIS is. We're the statewide agency, Office of Alcoholism and Substance Abuse Services. We serve all the counties in New York State. We have 1,600 prevention, treatment, and recovery programs, and we serve about 100,000 people a day in our programs. And we also operate 2 state addiction treatment facilities. They're state operated. One here is in Kingsborough, ATC. Just general information, we have a budget of $1.7 billion. We have 11,000 detox and treatment beds in the state. Let me tell you a little bit. I did a little research and found out what's happening in Kings County. Interesting enough, the primary substance for treatment services and admissions in Kings County is alcohol. And opioids comes in close second, marijuana and crack cocaine. And you can see here from this chart that, it's really starting to move up in terms of heroin and opioids. And this is, again, our admissions data. We keep data on individuals who are admitted to our system, be they are admitted to a program in Brooklyn, Kings County, or a program in Western New York. Again, some data. What I really wanted to talk to you about, a couple of things to build upon what the doctor had said. We do a youth development survey every couple of years, and we do a research in schools. We reach out to the school districts. They allow us to come in. One of the things we found in Kings County is 71% of high school seniors have used alcohol. 17% have done binge drinking, have engaged in binge drinking. 10% of 8th graders use alcohol in the past 30 days, and 7% of high school seniors have used prescription pain relievers non-medically. In other words, they've taken medication from their family's cabinets. So, I have to show a picture of the bosses. So there's my picture of the bosses. Please let everybody know that I showed pictures of the bosses. My boss is in the red suit, and the other boss is sitting down. I just wanted to let you know some of the things that we're doing, and I wish they were here years ago when my cousin suffered, when your family suffered with your son's addiction. But we are really trying to build the services that people need in New York State. We have family support navigators, and those are the people that are going to help people get through the system. What do I do? If you've ever had a situation with a young person in your family, you go, what am I going to do? That's what the family navigators are about. We are becoming very big in peer engagement. We have a certified peer engagement program. What are peer engagement specialists doing? Our peer engagement specialists in New York State, when they get a call from an emergency room that someone has overdosed, they go to that emergency room and they sit with that individual and they say, I was on that gurney. I was in that position. Or if they're working with a recovery center, they may be that individual a person in recovery goes to have a conversation. I would encourage everyone from the community, if you know someone who's in recovery who may consider being a peer, that is a very important piece of the work that we need to do in communities, because it's going to be people who are familiar that are going to be helpful to that individual. We have recovery centers, adolescent clubhouses, Vivitrol in jails, telehealth we're working on. In community services, we have a waiver from the federal government now. We can provide services, or our providers can provide services outside of the 4 walls of their treatment center. What does that mean? That means that we need to have conversations with the community, and we need to work with the Department of Health in New York City to say, where are locations where people might feel more comfortable coming and getting services, and pair together with community services, a community center, or some type of health clinic to get the treatment that they need. Legislative reforms. There used to be a time you would go in, you'd break your leg, you'd get 30-day supply of, I got 3 minutes, 30-day supply of medication. So that's changed 7 days. No prior authorization for medications. Inpatient, very important, no prior authorization for inpatient services and treatment services. We're expanding the lock zone. We're working with hospitals. We have a new assessment fund. I think the legislators have left that really is going to help us with our work. I'm going to go through these really quickly. So I guess I could have gone backwards. You see where the map was empty? I'm going to keep going. We are increasing services in New York State. We're expanding our capacity for opioid treatment. We have peers. We have opioid STR funding, some of which is coming to Kings County this year, and that is going to provide us with the opportunity. We're still reviewing who's going to get that funding, but it's going to provide for teleservices, so individuals can get services if they can't get to their treatment, mobile services. We have one STR grantee in Western New York who's actually got a mobile van and doing treatment in mobile vans. Important piece to add on to what the doctor has said. It's important, and there's one resource is going to your doctor to get services, but that talk therapy is very important. And you need to partner the medication with talk therapy. And that is something that we very much advocate for at Oasis. So we've been very busy, as you can see. So we have a lot of programs, peer engagement. The new enemy that we have now is fentanyl. You can see how small that is. We have a lot of resources on our webpage. You need to become informed. You need to get that information, know the signs, know things that I'd never thought of when we were working on this campaign. One of the mothers who we worked with, family member we worked with, she said all of a sudden she noticed that shoelaces were missing and spoons were missing, and she couldn't figure it out. And that was something that she said was a key thing to talk about. We have all these resources on our website, combataddiction.ny.gov. It helps you with prevention, warning signs, getting help, getting information, real stories, things that you can utilize. Again, more resources and campaigns that we're involved in. Before you show that, can I take that back? There we go. Reversing the stigma. We have that available on DVD. We have it available on a thumb drive, on YouTube. I would strongly recommend that as a community, please take the opportunity to view this video. It's real New Yorkers who are in recovery and talking about their stories of hope and recovery. And it's really been just an amazing opportunity to hear from people how they became addicted and the hope of recovery. Quickly, I want to show you 30 seconds. I promise it's 30. I promise. 30 seconds, our new campaign. Our new campaign, while they're really keying it up, these are people in recovery. This gentleman is not an actor. He wanted to give back to the community, give back to the state. This is part of a campaign we are doing focusing on the Latino community. We've also done a campaign, a new campaign, that's focusing on the Native American community. No? Yes? No? No? No?
Family, support professionals, my faith. I thought I was alone. I was afraid to talk about my addiction or to tell others that I needed help. But I didn't need to be. Support was all around me. My friends, family, support professionals, my faith. Today I am sober. And what I know now is that treatment is available. Recovery, possible. You do not have to be alone in your addiction.
I promise you just two more things I'm going to quickly show people. If I can get it to move. Move, no. Move. Commissioner has a television show that's on Telemundo in Spanish to talk about addiction, to give information out to the community. And so I just wanted to make sure everybody knew about that. Come on. I hate technology. I'm technology challenged. Quickly, Our website has a lot of information to help you through the process. One of the things that we have on our website is a thing called the treatment dashboard. You can put in what type of treatment you're looking for. It is updated on a daily basis by our treatment providers. Every day, they tell us how many slots, how many beds they have available in their treatment programs. So that is a very key piece of finding addiction treatment services that has the phone number. Call. Hopefully when you call, it's updated in the morning, but by the afternoon, it's very possible that that bed is taken or that slot is taken. But it gives you information about treatment services throughout the entire state. Here's our Hope line at Oasis. It's manned 24/7. Also, we have a text component to it, and people call you back if you need those services. We have more resources. And finally, the one other thing that I really wanted to mention is that we will be funding a 24/7 access center in Brooklyn. The commissioner, this is a big project for her. She feels it's important that people have access to service 24 hours a day, 7 days a week, because people don't decide they want to go to treatment Monday through Friday, 9 to 5. So it's going to be a resource where people can go to, emergency rooms can send people to, police departments can take individuals to. Again, thank you, Jakob. Thank you very much for, I know I'm rushing through. You have my slides so you can share them with individuals. Anything that you need or any information you need, we're here for you at Oasis, and thank you very much for your time this evening.
Operation Survival is actually funded by Oasis, so thank you. Although the role of law enforcement is important in the war on drugs, a wise man once told me, you can talk all you want about putting the drug dealers behind bars and putting pressure on the foreign countries that bring the supplies here, that bring the drugs here. As long as there's a demand, there's always going to be a supply. There's just too much money involved. You can go after the dealers all you want. As long as there are people buying, there's always going to be another dealer. You take one dealer off the street, there's a new dealer the next day. Just the way it is. Our next speaker is Jill Harris. She's the policy and strategy counsel to Brooklyn District Attorney Eric Gonzalez and the director of his Justice 2020 initiative. Prior to her current position, Harris was the deputy director of UCLA's Campaign for Smart Justice, where she focused on state-level criminal justice reforms. Before that, she worked at the Drug Policy Alliance as the managing director of policy and strategic initiatives. Harris is a graduate of Harvard University and the New York University School of Law. Jill.
Good evening. I'm happy to be here representing the Brooklyn District Attorney Eric Gonzalez, but for a previously scheduled engagement, he would be here and wishes he could be because this is an issue that he cares very passionately about. I want to thank Jakob Berman and Operation Survival for the important work that they're doing in the community. It's really just so important because, as we heard from Sara, is that your name? Who lost her son, there's so much shame that attaches to drug use in a family or in a community. And it prevents people from getting the help that they need. It prevents people from being open about this issue, prevents people from talking about it, and just takes something that is terrible, but maybe could be more manageable if people just weren't so full of shame about it. And one of the reasons that there's shame attached to it is that possession of drugs is a crime. You know, we criminalize drug use, and so that makes it all the more shameful. And so the district attorney, Eric Gonzalez, believes that drug use should be treated as a health issue rather than a criminal issue to the largest extent possible. And it's not possible in every case, but he believes that it's important to think of it as a health issue. If we think of addiction or substance use disorder as a disease, what other diseases do we treat this way. You know, if someone's a diabetic and they have to take insulin, but they don't take it and they get sick as a result, do we throw them in jail? You know, it just, in some ways, it doesn't make sense if we really do think we're talking about a disease. What would it look like if we didn't treat it in the criminal justice system? And so given that the laws are what the laws are, the district attorney has worked to move the cases out of the criminal justice system to the largest extent possible before a charge gets brought where we're able to do that. And so we piloted a program recently called Brooklyn Clear, which is modeled on a program that started in Staten Island called HOPE. And what this is, and Karen Variali from my office, that's her right there, she directs our Brooklyn Clear program and got it up and running. So the purpose of Brooklyn Clear is to allow people who are charged with possession of drugs to access services before they actually get far enough into the criminal justice system that they have a charge and they have to come to court. Because if you have a situation where someone has a substance use disorder and all of the negative consequences that come with that, both for the individual, for their family, for the community, for people who are impacted, and you compound that by giving that person a criminal record, then they're not allowed to get a job that could help them have more self-esteem and be better able to deal with their addiction. They're not going to be able to get housing, which is going to make them more stable and more in a position to fight their addiction. They're not going to be able to have access to certain services that are going to help. So you were basically just taking someone with a lot of problems and just making them worse by putting them in the criminal justice system. And so the district attorney, working with the New York City, the NYPD, and Deputy Commissioner Herman is here and will speak after me, and she and the NYPD have been partners in Clear. When someone is arrested, when someone is arrested for possession of a small quantity, a personal use quantity of drugs, this isn't someone who's got a lot of them and is selling them. We're talking about someone who's a user. If that person is arrested for possession of a controlled substance, which is a 220.03, we call it, in this section of the penal law, and they're eligible to get a desk appearance ticket, which basically means they don't have a warrant, they're not on probation or parole. There's no reason that they have to be held and taken through the system, but rather they can go to court on their own, almost as though they've gotten, a summons to go, but it's not a summons, it's actually called something else because it's a criminal matter. So if they're eligible for that, when they're at the precinct with the arresting officer notifies the DA's office that there's an individual in the precinct who's eligible for clear. And our office is notified. We dispatch from our provider a peer counselor. So this is somebody, the peer counselor, the peer mentor is someone who's not a member of the police department, not a member of the district attorney's office, not law enforcement at all, but rather somebody who has had their own struggle with addiction and drug misuse and can relate to the person who is sitting in the precinct next to the police officer. And so that person comes to the precinct and says, I see you're in a jam here. There's a program that the DA and the NYPD offer that's going to allow you to get out from under this charge. And really all you need to do is just go in, be assessed, just talk to someone about what's going on with you. They'll recommend some services that you might want to take advantage of. And then you just take advantage of one of these services and your charge is going to be dismissed without you having to even go to court. And the services, there are a range of services, treatment services, pre-treatment services. Sometimes it's an HIV test or some kind of housing application or a social security card or something that someone can do to improve their situation. Because we're not going to be able to insist in every single case that somebody stop using drugs that minute and never use drugs again from that minute on. And some of the drug courts and the drug alternative programs that have existed have had that very high bar in them, which is, if you can't be abstinent from now until forever, you're going to end up in prison because we just don't want you using drugs. And if you keep using drugs, you're going to go to prison because you're a bad person. And it just, It's just not the way to deal with a health issue. And so in Clear, the goal is for people to get off drugs. That's what we want. That's what they probably want. But we know that people aren't going to necessarily achieve that immediately. So we try to provide other things that are going to help them get more stable, help them build their self-esteem, help them build their life skills, so that they'll be in a position to get into treatment. And so this program was piloted. We started it in February, and it's been fairly successful. About half the people who come through the precincts and are eligible have gone into Clear, have done the program, and we actually feel like we can do better than that. We have talked to the peers and we're retraining them to make sure that we're sort of maximizing the extent to which people are going to want to avail themselves of the program. And then if people choose not to do the Clear program, then their case just basically goes to court as it would and gets processed as it would. And then in court also, we're trying to divert those cases out of the system. Again, we're not trying to give people criminal records if we can help it for simple drug possession. And again, we're not talking about drug sellers, we're talking about drug users. And so even when they get to court, if they're not doing Clear, sometimes there are other ways they could come back to Clear, or they could get other programs that would allow them to avoid having a criminal record. Because once you have a criminal record, as I sort of alluded to before, everything's just harder. And it's not like you're less likely to fight your addiction successfully. It's not like you're more likely to fight your addiction successfully. At that point, you're less likely to, because you just have this big strike against you. So we got money from the city council last year to pilot the program. Just yesterday, we expanded it to the rest of the precincts in Brooklyn South. And we hope to expand it borough-wide next fiscal year. And so we've gone to the city council and we've gone to the mayor and we've said, this is a successful program. They're doing it in other boroughs and we want to expand it in Brooklyn so that it's available to everyone in Brooklyn. It shouldn't depend where you live, which precinct you're in, whether you can have access to this program or you can't. So, we hope we get the money in the budget for that. Anyone here who's a staffer for a council member want to help us out with that, we really appreciate it. In the bags that you have, there's a brochure about Clear. It looks like this. It's colorful on the front. If you want more information, you can look at it there, and you can also call our office. So I just want to say I've only worked for the DA since roughly after his election. You heard from the bio, I'm not really a career prosecutor. But I'm very proud personally to be working for a district attorney who understands that drug use is a health issue, and not every response has to be sort of a heavy-handed criminal justice response. And in fact, we have to deal with this really important issue that is, taking so many lives and causing so much pain in our families and our communities, and just sort of deal with it in a more compassionate, a more health-based, a less stigmatizing way. So thank you for this opportunity.
Good evening, my name is Shia Hecht. A number of years ago, I was invited to open Congress with a prayer. I tell you, I was really very nervous. I'm going to get up there in front of hundreds of congresspeople, men and women, who are good speakers, and here I have to be able to present my blessing and to start the day off with some prayer that helps them move this country. And I get there, and they usher me through the back door, and I come into the front, and then I'm on the podium, and I look out. There is not one congressperson sitting there. The room is completely empty. And I think I'm crazy. And they tell me, go ahead, you're on. Now they introduce me. The only one is there is a speaker, and I do my shtick. I begin with prayer, and as I go off, there was one or two people who were working there who said, you did a great job. And I said, who was I speaking to? He says, don't worry, Rabbi. By the time you get out of Washington, you'll see how many of the Congress people and their staff saw it. And by the end of the day, there were so many people who came home and said, Rabbi, it was a great prayer. And I say the same thing this evening. We have a small crowd here, but hundreds are listening and watching us through the computers. Unfortunately, I'm supposed to help with the question and answers. We're running a little late. We will not have. But I make a pledge on behalf of Operation Survival of Yaakov, because I like to see other people work. And I'm going to make a pledge that we try to put together one evening that, being that most of the people are connected to us right now, hundreds of people through computers, that we work out that there's a question and answers, and we can really bring some of the professionals together to speak and really advise, as we heard from a mother of a child that lost a child, that if only we can really figure out what are the symptoms, what should we look for? Do we have a moral obligation to really to check into our children, to our teenagers, to our young adults? Do we have the right and perhaps obligation to go through their papers, to go into their bedrooms, to go through their drawers, to go through their papers, etc.? But it's I was only asked actually to introduce someone. I just wanted to bring that because we will not have time for questions and answers. I have a great honor this evening in introducing Susan Herman, who was the Deputy Commissioner in the Police Department for collaborative policing. Now, if you live in Crown Heights, or for that matter, if you live in the city, you know the most important thing that you're concerned about is the police. And you know how important it is not only for the police department, the way they take care of us, but we have to work together with them. And just a few years ago, many of these things were introduced where we work much closer with the police department, that it's not us and them, but it's all of us working together. And so having Susan Herman here this evening is really something very, very important. She's a member of the New York City Police Department from 1985 to 1990. She served as a special counsel to 3 different police commissioners. She was an associate professor in the Department of Criminal Justice for Pace University. She was an executive director for National Center for Victims of Crime. I must tell you, it goes on and on and on. But we are very, very proud, and in general, we are very, very happy with working with the precincts of our community and the people that are there, particularly those what we call the community policing, those dressed in blue. And to have Susan here this evening is a great honor for us, and we know will help push our important agenda one step further. So thank you, Susan.
It is true, when you get to a certain age, your resume is long. It's just the way it is. Thank you for inviting me to be here this evening. It's a pleasure to be here. I thank you, Yaakov, for putting all of this together. I've heard several of the speakers, and I'm going to try not to repeat things that others have said. Everybody has given really terrific information. I think you have a sense of the scope of the problem, or the essence of the problem in New York City and in Brooklyn. But I'd like to start by just giving you some numbers that I'm not sure you've had yet. Forgive me if I'm repeating this. Last year in the city, we experienced 1,441 fatal opioid overdoses. 1,441. In Brooklyn, 350 last year. This year, suspected fatal overdoses, and I say suspected because they haven't yet all been confirmed, but they're suspected that that's the reason for the cause of death. In 2018, just so far, 411, and in Brooklyn, 87. So far this year. What do we do in the police department when we hear numbers like this and we know that these numbers total more than homicides and car crashes? We equip every single police officer on patrol with Narcan, because the basic, most fundamental core value of the police department is to protect life. That's why police officers carry tourniquets. That's why they're trained in CPR. That's why they know how to deliver babies. And that's why they carry Narcan. And that's new, but this is where we are. This epidemic, this crisis, really accelerated over the last few years, as you've heard, because of fentanyl, very much so. It's a different situation. because of fentanyl. The risk of death is that much greater. So, as we carry naloxone or Narcan in 2017, the police department on its own, there are many other agencies, there's EMS, there are community-based organizations, but the police department administered Narcan 280 times and 56 times in Brooklyn. Yeah, it's pretty great. So there's one more thing, just another context note that I'd like to say. And I say hello to my partners here in the front. It's good to see you all. We know that many people face co-occurrence of mental health problems and substance use problems, that they go together frequently. We know that is our OASAS speaker still here? Yes? My sense of your statistics are that almost half of the non-crisis discharges, so somebody who left an OASAS-funded facility not for a crisis, almost half of them involved patients with co-occurring substance use and mental health disorders. That's a significant statement. So what are we about, all of us? The push is to get people to treatment. And when law enforcement is involved, it's leverage. And that's what it is, and it's a motivator. But I'm going to say this now, and I'm going to say this at the end. We shouldn't need law enforcement leverage or motivation to get people into treatment. Often that's what works. Often that is the bottom for people. Often that is the turning point. But we have enough treatment options in New York City. I'm not talking about other counties in New York. I'm not talking about other states. I'm not talking about other jurisdictions around the country that can't say this. In New York City, we have enough treatment and enough treatment options that everyone who wants treatment should be able to access treatment. We can say that. So our challenge as a community is to figure out all the different ways to overcome all the barriers that exist to get people into treatment. You've heard about stigma. You've heard about people not knowing where they can turn. You've heard about maybe it's closed, it's not 24 hours. There are lots of barriers. But that's our challenge, all of us. And that's what I give this audience here in the room and those of you watching. Our challenge is to figure out how to motivate people beyond criminal justice leverage. So you've heard about CLEAR. We are very proud partners in the CLEAR initiative. I was waiting to hear that it expanded yesterday. I'm glad that that happened, and we will expand it again to all of Brooklyn in the next fiscal year. So I don't need to tell you about CLEAR. I want to tell you about some initiatives that you may not know about. Another initiative, another partnership, this time with the health department. There are 2 community health diversion centers that will be opening in New York City during 2018. And my hope is that we have many more to follow. This is a very interesting model that already has been tried in other jurisdictions where police officers are able to see someone who may have committed a low-level violation, may be known to be or believed to be someone who has either a mental health or substance use problem, and the police officer can offer to the person pre-arrest services that are completely voluntary. Is there leverage? Is there a little bit of an or else? If you don't accept these, we may arrest you right now. We could do that, but it's voluntary. There is no court looking at you. There's no date. There's nothing hanging over your head if you accept these services. These are community health diversion centers where they're kind of a misnomer because they're not really community health clinics. The only way you get to go to these centers is if a police officer brings you there. So what that means is it's a dedicated pre-arrest diversion option for officers. It's another tool in our toolbox. CLEAR and HOPE that you heard about, which is in Staten Island and soon to be in the Bronx, those are post-arrest, pre-arraignment options. What that means is you're already a little bit in, and as you heard, you don't have to go to court if you engage in different time periods. This is, if you engage now, if you go to this center, it's completely pre-arrest. There's nothing. There's no record of this encounter. You would go to a center that has a certain small amount of beds, small amount of chairs for people to be there overnight if they need to be, get mental health or substance use treatment, short-term case management to connect you to ongoing health care and treatment in the community. This is a terrific model. It's the answer to the question that officers ask all the time. This person has a problem. What am I supposed to do with this person? Where am I supposed to take this person? They're not quite bad enough that I should be taking them to a psychiatric ward because they're in the moment dangerous to themselves or others. And yet, they're bad enough that if there is no intervention, either their social problems, their health problems, or their criminal justice problems are going to get worse. So what do I do with this person? And I think these centers will fill that void for a lot of people, and I'm very, very excited about this. So you have to be 18 years old. That's one limitation, because you're making that decision to accept this. We think you can be there for up to 3 days. There'll be nursing staff there, clinical staff there. There will be peers there as well to talk to people and work with them, and there'll be security there. We hope that officers are there literally no more than 5 to 10 minutes. Here you are. Here, comfortable, everybody happy, anybody need to know anything? Good luck. And I hope you get what you need right here. So that's a great option. The second initiative that I want to tell you about, I hope you already know about. I hope you saw great posters that we had running in New York City for 4 months that told all New Yorkers about the Good Samaritan Law, the New York State Good Samaritan Law, which says that if you're seeking help for yourself or for someone else during an overdose, that you will not be arrested. The caller or the person you're calling about during an overdose, you will not be arrested. So that's a message that the New York City Police Department wanted all New Yorkers to know. Do not ever hesitate to call 911. We will come, we will help you, EMS will come, nobody's getting arrested. Never, never hesitate to call 911. So I hope you saw that campaign. It was up in buses, subways, Staten Island Ferry. We pushed it out on cell phones. We even had a mobile billboard truck driving around the city. How many of you saw it? That's it? Okay, sorry, you should have seen it, but now you have heard the message. Please spread that word. No one should ever hesitate to call 911. There's one more initiative that I want to tell you about because I want you to really appreciate, I hope, that your government is working on your behalf. We believe that if everybody knew what the answer was to the opioid crisis, we wouldn't have an opioid crisis, right? If everybody knew exactly what to do, we'd be doing it. So we decided as city agencies to come together voluntarily 4 times a year to review cases of fatal overdoses. And it's government agencies sitting around one table in police headquarters looking at what happened in each of these cases. Is there any way that anything could have been done if the protocol was different, if the policy was different, if you had different resources at your disposal? What might have been done differently to save this person's life? Could anything have been done? We meet together, and it's about 30 to 35 agencies, city and state agencies, who sit around a table. We meet together, we talk about these cases, we raise issues, and quite frankly, and this is the part I like, but it sounds strange when I say it, we don't try and solve any problems at these meetings. All we do at these meetings is identify issues. What about if these people had Narcan? What if these people had been open 24 hours a day? What about if these people had a different kind of screening test? So we identify issues, and out of these 3-hour meetings, there are about 30 to 40 issues that get identified each time. In between these meetings, we try and address those issues. That's what that time is for. And then that's a pretty tight deadline in city government. You got 3 months to try and resolve this. And the beginning of each meeting, we talk about the progress that was made from the meeting before. And I tell you this just to say, I want you to know that we are all struggling with this. We've made lots of improvements as a result of those meetings. Lots of things have changed. There are more resources. There are different policies. There are different protocols. The state is at the table. OASS is at the table. Regional government agencies are at the table. It's law enforcement, health, probation, parole, homeless services. Everybody's around the table together. So, I promised you that I'd be short. I want you to understand that we are doing interesting and creative things. I think it's meetings like this where we can learn from you and hear what your questions are. But 2 things I want you to know. There are 2 numbers that you've got to keep in your head. One is never hesitate to call 911 in the event of an overdose. Nobody's getting arrested. And the other is 1-888-NYC-WELL. You call about yourself, or you can call about someone else. And you can describe what the situation is. You should be able to get connected to mental health or substance use services from NYC-WELL. And if you have any issue with that, if you call and you can't get through, you can call me. But I mean that 100%. NYC-WELL is, have you ever heard of LifeNet? Do you remember LifeNet? So LifeNet doesn't exist anymore. LifeNet was pretty much a suicide prevention hotline. NYC-WELL is LifeNet on steroids. It's about many different topics. It's 24 hours a day, and you should be able to access a wide range of services. Don't hesitate to call. Thank you.
The good news is we only have one more speaker. And in introduction to the speaker, in 1991, when I went for my training to Rutgers School of Alcoholism, I learned very clearly that addiction is an illness, and it strikes all, no matter what color, no matter what age, no matter what religion, et cetera, et cetera. So as I asked the next speaker to speak, I would like you to use your imagination and look at this person as if it was someone from your own family, from your own community. So I'll be looking at him, looking a little bit like a rabbi, perhaps wearing a yarmulke and a beard. But I called to the microphone Jay Mcray and to share a little bit of his own story, and just give him a few minutes, and then we'll wrap up the evening just giving the thank yous to the elected officials and all those other from the hospitals and different agencies that came here to help us this evening.
Thank you so much. My name is Jay Mcray, and I am in recovery. I was a 15-year-old heroin addict. I'm from Harlem, New York. I wanted to see my, I tell people that I have a PhD from UCLA, but I don't tell them that it's the university on the corner of Lenox Avenue. You see, I'm now 66 years old, and I've been clean for 16 consecutive years. Thanks for the clap, but if you do the math, you know that for 35 years I struggled. And I struggled through the time, through my teen years. I stopped. I went into the United States Air Force, where I started back, and I did 4 years in there, totally getting high, and nothing I could do could help me stop. I went from one drug to another. I sympathize so much with you because, like your family, I sat down every night at the dinner table with my mother, my father, sister, and brother, and we ate dinner together. I had a loving neighborhood. My neighborhood, we still have cookouts together 3 times a year. Everybody looked out for everybody. It was a racially mixed neighborhood. The problem wasn't the neighborhood, it wasn't the parents, it was my individual choice and the way I felt about myself. I was in a bad fire when I was 3 years old. I was burnt very bad. I have the plastic surgery on my hand. I had plastic surgery on my face. All my hair was burnt out. They said it would never grow. Up until about 4 years ago, I had dreadlocks this long. I just didn't like who I was, and I needed to change that. So I looked for mood-altering substances to do that. I started out when I was very young. I was like 13 or 12. I started drinking this stuff called rock and rye. I loved the way it made me feel, but eventually that didn't help. So I moved on to smoking weed for about a year. Then it was sniffing heroin. Then it was skin-popping heroin, where you just inject it right under the skin. By the time I was 14, I was mainlining. By the time I was 15, I went to my first OASIS program. That was when Phoenix House had an after-school program that I had to go to at the age of 15 years old. I struggled with addiction. Wow, and the things that I went through with the struggle, it's so hard to explain, you know, when you don't like the skin that you're in. You know, I can, you know, get along with everybody. You know, I had no problem with that, but when I was alone by myself, I had issues. And that continued until I finally got what was wrong. What was wrong was me. It wasn't nothing else in the world going on that was wrong. People weren't seeing things in me that I thought they were. I met this young lady and her mother one summer that I went my entire elementary school years with her to school, and I forgot to take my package off in the mailbox, and she said, don't forget to take your package down. And I reached for it, and she grabbed my hand, and she said, Jay, what happened? I said, I got burnt. She asked me when. The thing that bothered me so much in elementary school was that everybody was going to notice the burn on my hand. This girl went to school with me from kindergarten to 6th grade, and she didn't even know I was burnt. The only thing that mattered was that it was in my mind. Some of the things that people, you know, well, I am now a certified recovery coach. I work at, I do volunteer work at 20 New York with Pat Waldridge. And we know that every addict knows what's in them, what makes them do what they're doing. But they also have the answer on how to stop. We have the education, you know, to give people all of these ideas on what might make a person stop using. Every addict has his own reason to stop. He has his own key to unlock that door to sobriety. No two people are going to use the same way to stop getting high. I also retired from this agency called Do It. That's the Department of Information Technology and Telecommunication for the City of New York, where I worked for 30 years and where they paid for about 9 recoveries for me. And every time I went, my only thought was, I'll go into recovery right before I put in for a loan, go into recovery, come out, get the money, and then start back getting high. I figured that out. That was like my Club Med every year on the city's dime. And I would have continued to do that except by one day, I said, I can't do this anymore because the money I was spending wasn't giving me the same effect, and I was still spending the money. I went to a 12-step program, and I read this thing called How It Works. And every time I went to a meeting, I tell a guy, I need to read How It Works. And I read it. And one day I went in there and I went to read it, and I'm like, wait a minute, How It Works. Now, I have read this thing. Every time I went to a 12-step program, I end up back there on the street. But what I didn't do is I didn't implement those steps into my life. And the light bulb went off. I said, this is what you have to do, not what you have to read. And I started doing that. And yes, I am bragging. I mean, for over 16 consecutive years, I haven't taken a drink, I haven't taken a drug. 14 years, I haven't even smoked a cigarette, by the grace of God and by the help of my community. You see, there's people that I do know how to call on. I was speaking to a young lady today, Rebecca, and one of the things that I mentioned to her that it was so powerful in my move away from doing what I was doing is getting away from the people I was doing it with. You cannot stay sober and stay around the same people that's getting you high. It's just not gonna work. It never does. You have to make major moves, and you really have to dig deep if you want to stop this. Our opioid epidemic, to me, and you have to understand where I'm coming from, because I'm not from Brooklyn. I'm from Harlem. And I grew up, I was born in 1952. I'm a boomer. I didn't know that there wasn't an opioid epidemic, ever. We've always had it. Every day, like, I was talking about how desensitized we get to seeing stuff. Like, for me to see somebody on the corner, all right, he got the good shit. The thing that's so crazy about an addict, when I was on heroin, and this is one of the reasons that they're mixing the little fentanyl with your heroin, is because it makes it so potent. If one person OD, guess what happens to all the other people who are heroin addicts? They want that drug. They want the one that made someone OD. Now, how insane is that shit? We don't understand the depth of what's going on. This is like you're basically trying to commit suicide, but you don't want to say it. You just want to do it in your action. You say, okay, I'm trying to get high. No, you're not. When you go look for a drug that's making other people OD, and that's the one you want to buy, you're trying to commit suicide. But it's not because you want to, it's because of the pain that you're going through. You need something to subside that pain, and you haven't found the right way yet. We have recovery centers. We have, like I said, I'm a recovery coach, and we do things a little different. We do have one-on-ones with people. We talk to them. And I know I have a great respect for the medical field, but if I'm in need of help, give me an addict in recovery to talk to me. No one else is going to know my pain. And this is from the bottom of my heart. Wow, it's so much that I need to say that I can't even say in the time allotted. But what I do want to say is those numbers that we're giving you, write them down. Because everybody in here knows somebody or related to someone who has a problem. Thank you for letting me share that with you.
I want to take this opportunity to thank everybody for coming. I want to thank, of course, Yaakov and his staff, Miriam, and everybody else that works at the office at Operation Survival. Please make sure to take your bags. Yes, operationsurvival.org if you need to reach us, or 718-735-0200 or 0230. I want to thank the NYPD. I want to thank the District Attorney of Kings County, Empower Assistance Care, Vocal New York, the Legal Aid Society, New York City Health, and of course the New York City Council, all our elected officials of this neighborhood. God bless them. They're doing a good job for us and fighting for us. Of course, the police department overall. Please, my dear friends, if you think of an idea of how we can help other people, call Yaakov, call our office, let us know what you think. We need feedback from you. We need ideas. For those of you who are listening on the computers and watching this program, I want to thank you for joining us. And likewise, please email us at operationsurvival.org. Let us know what you think. I've personally received this evening, just sitting here on my phone, quite a few texts. I do appreciate for those of you who are reaching out. And then again, help us help others. As mentioned by Jay, we all know someone suffering. We all know someone in pain. We all know someone who needs our help. A little bit of love. If we reach out, and as he mentioned, his community was the ones who really saved him and helped him. And we as a community have to join together with a little bit of love and a little sensitivity. We got to reach out, and we can be successful in doing this job together. Once again, God bless you. Those of you who shared this evening on your personal level, may Hashem really give us the strength. And my dear friends, I do have the answer to all the problems. And that is, if we all do a little bit more goodness and kindness, we'll bring the Messiah and we'll make the world a place of peace and love. God bless you all. Thank you.